Hello students, welcome to the PEDS Pointers, your ultimate revision series in pediatrics. The today's topic is childhood tumors. We'll be discussing the hematological malignancies, mainly acute lymphoblastic leukemia and Langerhans cell histiocytosis. Acute lymphoblastic leukemia is the most common malignant tumor in children. You should remember the genetic changes are 4: hyperploidy, hypoploidy, translocation 922 Philadelphia chromosome and translocation 1221. Out of these 4, the most common is the hyperploidy. 85% of acute lymphoblastic leukemia arises from the B cells. So what can be the clinical features? It is a leukemia, is going to involve the bone marrow. There can be metastasis. There can be extramedullary involvement. In the bone particularly, if the B cells multiply, what happens to the myeloid cells? They are decreased. So there can be anemia, thrombocytopenia, granulocytopenia. Right? Bone marrow expands, periosteum is stretched, there can be presence of the bony pain. So bony pain and cytopenias, that can be seen here. Extramedullary involvement, the leukemic cells can multiply in the liver, spleen and lymph nodes, causing hepatomegaly, splenomegaly and lymphadenopathy. Metastasis can be to the brain and the testis, CNS plus testicular involvement is there. Flow cytometry, because 85% arises from the B cell, the pre-B cell markers are present, CD10 and CD19. The leukemic cells are also positive for terminal deoxynucleotide transferase, that is TDT. What we say, they are also positive for the TDT, terminal deoxynucleotide transferase is there. Prognosis, favorable, unfavorable. Age, 1 to 10 years is favorable, less than 1 or more than 10 becomes unfavorable. WBC count, less than 50,000 is favorable, more than 50,000 is unfavorable. Genetic changes, hyperploidy is favorable, and hyperploidy was also favorable in neuroblastoma. Hypoploidy is unfavorable. Females favorable, male unfavorable. No metastasis, of course favorable, and unfavorable will be if metastasis is present. Treatment, in the short I have given only regarding the induction phase and the maintenance phase. In the induction, initially you give 3 drugs, you can remember by PCV, pegylated asparaginase, corticosteroids, vincristine, plus there is chances of CNS involvement, so you will always give intrathecal methotrexate plus cytarabine. If there is a high risk, you also add donomycin. If translocation 922 present, you also add imatinib. That is the initial induction phase. Maintenance phase, from PCV, you remember by MCV, you can give mercaptopurine and methotrexate, corticosteroids and the vincristine. Acute lymphoblastic leukemia has chances of a relapse. If there is a bone marrow relapse, we give intense chemotherapy followed by bone marrow transplantation. So that is the revision of the acute lymphoblastic leukemia. Talking of the Langerhans cell histiocytosis, this is proliferation of the dendritic cells, and dendritic cells basically contains is the Burback granules. Burback granules, this is a mutation in the BRAF gene. This is positive for CD207 and CD1A. So proliferation of dendritic cell, Burback granules, mutation in BRAF gene, CD207, CD1A. This can present as a single system disease or multi-system disease. Single system can involve bone, skin or the lymph node. And if we consider the bony involvement, the most common affected is the skull. And the multiple questions you get is because of that. This can damage the mastoid area, can becomes a risk factor for otitis media. This can damage the pituitary gland, can cause diabetes insipidus and hypothyroidism, and this can also cause exophthalmos. So this is basically the skull involvement which is there. Lungs is no longer considered to be a risk organ. Treatment, single system or multi-system. Single system, usually there is spontaneous remission, and multi-system we are giving is vinblastine plus corticosteroids. So this was in short regarding the hematological malignancies. Do revise it, do subscribe to the channel. Happy learning.